must correct you. It's actually the AATS guidelines, but I don't think anybody's going to really matter. It was over about a year ago that the ATS asked me to form a writing committee to look at ways to prevent myastenitis and sternal wound infections. And our goals were really to develop guidelines for the preoperative, intraoperative, and postoperative periods, and also to establish principles for what would be the most effective methods to treat sternal wound infections when they occurred to lower morbidity and mortality. And we all know that the impact of sternal wound infections is very profound, increases morbidity and mortality, decreases long-term expectancy of life, prolongs hospital length of stay, and actually raises hospital costs by as much as $62,000. It's also publicly reported, and it was mentioned earlier, CMS will no longer pay in the United States for reimbursement for hospital costs for patients who have sternal wound infections, and it's been mentioned numerous times this morning. It is a major concern if we're going to do bilateral mammary grafting. Now, just briefly to review, you'll see a lot of classifications and level of evidence. A Class 1 recommendation is a treatment that should be performed and is recommended. Class 2 is divided into A and B. A being a procedure which is reasonable to perform, it's effective, beneficial, and it's probably recommended, whereas Class 2B is one that might be considered useful, but it's not as well established. And Class 3 is a procedure that should not be performed. The level of recommendations range from A, which has randomized multiple trials and analyses, to C, which is basically standard of care and case studies. Now, beginning with the preoperative state, we feel that all cardiac surgery patients should have nasal swabs and PCR testing prior to surgery. And the advantages of the PCR assay is it really is more accurate to identify those patients who are nasal carriers of staph organisms, which are the predominant organisms for sternal infections. And also it reduces the cost of mupirocin, but does not interfere with the incidence of staph infections. The disadvantage is that it's expensive and it's not available in the vast majority of medical centers. So we feel that routine mupirocin administration is recommended for all patients undergoing cardiac surgery in the absence of documented negative PCR testing or negative nasal swab. It should be administered to the nose starting within 24 hours of surgery and continued for 5 days. It has been shown to significantly decrease both superficial and deep sternal wound infections, but it has no effect in negative nasal staph carriers and in patients who have a negative PCR assay, hence the importance of determining this preoperatively. Now, cleanliness is next to godliness, and we feel that all patients should have some pre-op bathing with an antiseptic soap, but it's been shown that while chlorhexidine and other bacterial soaps may reduce the incidence of sternal wound infections, may reduce the bacterial counts, they by themselves do not reduce the incidence of sternal wound infections. Now, we agree with the STS guidelines that all patients should have a cephalosporin given within 60 minutes of the skin incision, but continue for no longer than 48 hours. It should be weight-based and redosed for those longer procedures. Now, vancomycin should be reserved only for those patients who have a history to penicillin allergy, but also in those cases where MRSA is of special concern. For example, patients who've been in the hospital for more than 3 days, they've been transferred from another inpatient facility, if you're doing a valve or a vascular graft, and those institutions that have a high incidence of MRSA are going through a major outbreak. On the other hand, vancomycin alone is not recommended as a sole prophylactic antibiotic in cardiac surgery procedures, essentially because it's limited to gram-positive bacteria, especially only MRSA and MRSE. And we've also touched upon some other areas in our guidelines. We feel strongly that preoperative nutrition is important, and those patients who have an albumin less than 2.5 is associated with a higher risk of sternal wound infections. And if possible, the surgery should be delayed for 7 to 10 days, and these patients should be given some enteral nutrition. In addition, all those patients who have a distant extrathoracic infection, such as a skin infection or UTI, should also be treated prior to cardiac surgical procedures, again, if the procedure can be delayed. As was mentioned earlier, we feel that it's important to optimize glycemic control for those patients who have an elevated hemoglobin A1C, those patients who have high glucose levels. We don't believe that surgery should be delayed, but certainly insulin infusion should be instituted in these patients before surgery. And there's been a lot of controversy about smoking cessation, but we feel that it is beneficial to stop smoking, and these patients should receive aggressive pulmonary toilet, and those patients who are really active smokers and those with significant COPD. Now in the operating room, again, the cephalosporin should be administered within 60 minutes of the procedure and redosed at appropriate intervals during the surgery. If you're going to use vancomycin, it should be given between 60 and 120 minutes prior to the incision. And again, we feel that a continuous insulin infusion is the best way to maintain serum glucose less than 180 in those patients who are hyperglycemic. Now, for the first time, we're also going to comment on the use of topical antibiotics. And we feel strongly that topical antibiotics should be applied to the cut edges of the sternum upon opening and prior to closing in all cardiac surgery procedures where sternotomy is being used. Now, here's some data from a study that we did and presented 2 years ago at the ATS. We had a group of patients where we used topical vancomycin, both after opening the sternum before closing, versus a group of patients that did not have this. And you can see we were able to eliminate both superficial and deep sternal wound infections in all patients, including diabetics. We feel that topical vancomycin is especially advantageous because it's easy to prepare and handle, it's inexpensive, doesn't result in any systemic or local adverse effects, there's no skin drainage, and it provides both bacteriostatic and bactericidal protection against gram-positive bacteria as well as Clostridium. We feel that bone wax should not be used at all for any sternal procedures. It inhibits formation of new bone, prevents bony union, may actually increase the incidence of sternal dehiscence and sternal infections, and it has not really been shown to limit blood loss or the use of blood products. In addition, we feel that using a figure-of-8 configuration is better to prevent sternal dehiscence and wound infections. In my practice, I use cables, but wires are also good. If you have a patient with multiple fractures, a Robicheck weave will probably help to prevent sternal dehiscence and wound infections. Rigid sternal fixation with bands or plates can be used. The evidence for this is less robust, may be advantageous in some very obese patients, but it's also more expensive. It's been associated with seromas and hematomas. Similarly, external chest supports may limit the incidence of dehiscence, but they are cumbersome, compliance may be poor, and I think we need some more data. And we've also commented some postoperative techniques. We feel that, again, antibiotics should be continued postoperatively, but for no longer than 48 hours. And again, all patients exhibiting glucose is greater than 180 should have a continuous insulin infusion for at least 24 hours in the ICU. Now, we also feel that the use of dilute iodine irrigation systems is actually harmful and should be avoided. They've been associated with increased renal toxicity. They interfere with thyroid metabolism, and has also been associated with CNS complications. And there are some reports that suggest that they decrease vein graft patency. We are, however, very optimistic about the use of wound vac therapy. We feel that it should be initiated whenever possible in those patients who have delayed sternal closure and for deep sternal wound infection. It's been shown to stabilize the chest wall, it allows for earlier extubation, removes excess fluid, reduces wound edema. The time taken or needed to sterilize the wound is definitely shortened. It's been shown to reduce hospital stay. It's probably cost effective, and there are a lot of reports now that suggest that it improves early and long-term survival. We also feel strongly if you're going to use a wound vac, it's necessary to place a dressing barrier between the sponge and the heart and great vessels to prevent catastrophic fatal hemorrhage. So then, in summary, if we were to summarize the essential principles and steps, we feel that all patients should have some sort of antibiotic bath prior to surgery, and they should all have nasal mupirocin, especially if you can't get a culture prior to surgery. That the cephalosporin antibiotics are important. They should be dosed accordingly, but not be given for more than 48 hours. Continuous insulin infusions should be started pre-op if necessary, but definitely intra-op and post-op. Keep serum glucose less than 180. Topical antibiotics are extremely important. In this case, we favor vancomycin given to the cut edges of the sternum immediately following sternotomy and prior to closure. Bone wax should be avoided. And if you do have a sternum that has multiple fractures, strong consideration should be given to a Robocheck weave. A figure of 8 technique seems to be superior. Thank you very much.